This recorded lecture will be going over Chapter 24, The Child with a Musculoskeletal Condition. A marked deceleration of growth is always a signal for investigation. The pediatric skeletal system differs from the adult skeletal system in that the bone is not completely ossified. Epiphyses are present, and the periosteum is thicker and produces callus more rapidly than in the adult. On page 571, figure 24.1 will describe some differences between the child's and the adult's skeletal and musculoskeletal systems. Any delay in neurological development can cause a delay in the mastery of motor skills, which can alter skeletal growth. Children who do not walk independently by 18 months of age have a serious delay and should be referred to a healthcare provider for follow-up. By 4 years of age, the child can hop on one foot and arm swings occur with walking. By 6 years of age, the gait resembles the adult walk with equal stride lengths and associated arm swing. Young children appear bow-legged or knock-kneed with the knees turned inward until 5 years of age. The role of the nurse is to reassure parents that unless there is associated pain or a problem with motor or nerve functions, many minor abnormal appearing alignments will spontaneously resolve with activity. The nurse should assess symmetry of movement and the strength and contour of the body and extremities. An assessment of reflexes, a sensory assessment, and the presence or absence of spasms should be noted. Radiographs are taken to confirm a suspected pathological condition. A complete blood count and erythrocyte sedimentation rate can rule out septic arthritis or osteomyelitis. Rheumatoid factor can help diagnose rheumatological disorders. A thorough history is necessary to determine the basis for musculoskeletal problems, which are often insidious. Traction, casting, and splints are used in accordance with the patient's needs. 3 types of skin traction, often used for the lower extremities of children, include Bryant's traction, Buck's extension, and Russell traction. Nursing interventions will focus on maintaining body functions. Soft tissue injuries typically accompany traumatic fractures in the child at play or the adolescent involved in sports activities. Soft tissue injury should be treated immediately to limit damage from edema and bleeding. When an elastic bandage is used for compression, a priority nursing responsibility is to perform frequent neurovascular checks to ensure adequate tissue perfusion. The principles of managing soft tissue injuries consist of rest, ice, compression, and elevation. Nurses are responsible for educating parents and school teachers about how to prevent accidental injury and maintain a safe environment. A fracture is a break in a bone and is usually caused by accidents. It is characterized by pain, tenderness on movement, and swelling. Figure 24.2 will illustrate the various types of fractures. When an X-ray film shows multiple fractures at various stages of healing, child abuse should be suspected. A fracture heals more rapidly in an adult than it does in a child than it does in an adult. Fractures of the femur are one of the most prevalent serious breaks that occur during early childhood. A forceful twisting motion of the femur will lead to a spiral fracture. When the history of injury does not correlate with X-ray findings, child abuse should be suspected because spiral fractures could be the result of manual twisting of the extremity. Skin traction is used to reduce the fracture and keep the bones in proper alignment. Most bone fractures are manually reduced or surgically pinned in place. Traction is avoided whenever possible because it involves long-term bed rest and resulting complications. Bryant's traction is used for treating fractures of the femur in children younger than 2 years of age or lighter than 9.09 kilograms to 13.64 kilograms. Traction is used when the cast cannot maintain alignment of the 2 bone fragments. Buck's extension or Buck skin traction is a type of skin traction used in fractures of the femur and in hip and knee contractures. Russell's traction is similar to Buck's extension. However, a sling is positioned under the knee, which suspends the distal thigh above the bed. You can see images of this on page 574 and 575. In skeletal traction, a Steinmann pin or Kirschner wire is inserted into the bone, and traction is applied to the pin. Daily cleansing of the pin site is essential. Skeletal traction carries the added risk of infection from skin bacteria that can cause osteomyelitis. The nurse observes the traction ropes to be sure they are intact with the wheel grooves of the pulleys and that the child's body is in good alignment. The weights should not be removed after they are applied. The nurse performs frequent neurovascular checks to the toes to see that they are warm and the color is good. The child is encouraged to drink plenty of fluids and eat foods high in roughage to prevent constipation caused by lack of exercise. Because the child in traction is unable to sit upright when eating, special precautions to prevent choking and aspiration during mealtime are a priority nursing intervention. Diversional therapy is important because hospitalization may be lengthy. When prolonged hospitalization is necessary, the child's school should be contacted to provide appropriate study materials in order to help the child maintain their current grade status. Compartment syndrome is a progressive loss of tissue perfusion caused by an increase in pressure resulting from edema or swelling that presses on the vessels and tissues. This can be caused by a cast that is too tight and compromises circulation, or by excessive edema that causes ischemia. Nursing responsibilities include elevating the affected extremity on a pillow and performing frequent neurovascular checks on the distal digits. Parents are also taught how to check whether the cast is too loose or too tight and when to return to the clinic or healthcare provider. Osteomyelitis is an infection of the bone that generally occurs in children younger than 1 year of age and in those between 5 and 14 years of age. Osteomyelitis can be preceded by a local injury to the bone, like an open fracture, burn, or contamination during surgery. The vessels in the affected area are compressed, and thrombosis occurs, producing ischemia and pain. Older children can localize this pain and may limp. Younger children and infants will show decreased voluntary movement of that extremity. There is an elevation in white blood cell count and erythrocyte sedimentation rate. X-ray examination can initially fail to reveal the infection. A microbiology culture of aspirated drainage or bone scan can be diagnostic. IV antibiotics will be prescribed for 4 to 6 week period. The high doses required indicate a nursing responsibility to monitor the infant or child for toxic responses and ensure long-term compliance. Bed rest is followed by wheelchair access, but weight bearing should be avoided. The muscular dystrophies are a group of disorders in which progressive muscle degeneration occurs. The childhood form, known as Duchenne's muscular dystrophy, is the most common type. Symptoms are noted generally between 2 and 6 years of age. The calf muscles in particular become hypertrophied. Other signs include progressive weakness, as evidenced by frequent falling, clumsiness, contractures of the ankles and hips, and Gower's maneuver. Muscle biopsy will show a degeneration of muscle fibers and the replacement by fat and connective tissue, and is considered diagnostic. Death usually results from cardiac failure or respiratory tract infection. Treatment at this time is to mainly supportive to prevent contractures and maintain quality of life. A slipped femoral capital epiphysis, or SFCE, also known as coxa vara, is the spontaneous displacement of the epiphysis of the femur. It most often occurs during rapid growth of the pre-adolescent and is not related to trauma. More than 80% of children with SFCE are obese. Symptoms include thigh pain and a limp or the inability to bear weight on the involved leg. An X-ray study will confirm the diagnosis. The child is placed in traction to minimize further slippage, and then surgery is scheduled to insert a screw to stabilize the bone. The general principles of caring for a child in traction and pre-op and post-operative care are used. Education concerning management of weight is important post-operatively. Legg-Calvé-Perthes disease is one of a group of disorders called the osteochondroses, in which the blood supply to the epiphysis or end of the bone is disrupted. This disease is seen most commonly in boys between 5 and 12 years of age. Symptoms include thigh and knee pain, a painless limp, and limitation of motion. X-ray films and bone scans will confirm the diagnosis. Legg-Calvé-Perthes disease is a self-limiting disorder that heals spontaneously, but slowly, throughout the course of 2 to 4 years. The treatment involves keeping the femoral head deep in the socket while it heals and preventing weight bearing. Nursing considerations will depend on the age of the patient and the type of treatment. Osteosarcoma is a primary malignant tumor of the long bones. The mean age of onset of osteosarcoma is between 10 and 15 years of age, and it occurs most commonly in tall adolescents in the midst of rapid bone growth. The cause is genetic. The patient experiences pain and swelling at the site. Diagnosis is confirmed by X-ray. Treatment of the patient with osteosarcoma consists of surgery, chemotherapy, and radiation. Long-term survival is possible with early diagnosis and treatment. The nursing care is similar to that for other types of cancer. Phantom limb pain is likely to be experienced. Ewing sarcoma is a malignant growth that occurs in the marrow of long bones. This occurs mainly in older school-age children and early adolescents. Amputation is not generally recommended for Ewing sarcoma because the tumor is sensitive to radiation therapy and chemotherapy. Juvenile idiopathic arthritis is the most common arthritic condition of childhood. It is a systemic autoimmune disease that involves the joints, connective tissues, and viscera, and it differs somewhat from the adult rheumatoid arthritis. JIA has several distinct classifications: oligoarthritis, polyarthritis, systemic arthritis. The goals of therapy are to accomplish the following: reduce joint pain and swelling, promote mobility and preserve joint function, promote growth and development, promote independent functioning, and help the child and family adjust to living with a chronic disease. Physical and occupational therapy will preserve joint function and mobility. Therapeutic play can facilitate compliance with exercise regimens. JIA inhibits the child's social interactions and can interfere with the development of a positive self-concept. This long-term disease is characterized by periods of remission and exacerbations. Torticollis is a condition in which the neck motion is limited and the cervical spine is rotated due to a shortening of the sternocleidomastoid muscle. This can either be congenital or acquired and can either be acute or chronic. The infant will hold their head to the side of the muscle involved. There is a hard, palpable mass of dense fibrotic tissue within the muscle. Surgical correction is indicated if the condition persists beyond 2 years of age. Scoliosis refers to an S-shaped curve of the spine. Untreated progressive scoliosis can lead to back pain, fatigue, disability, and heart and lung complications. There are 2 types of scoliosis: functional and structural. Symptoms develop slowly and are not painful, so detection is usually via a screening test performed by the school nurse that reveals shoulders that are different heights, a one-sided rib bump, and a prominent scapula. Definitive diagnosis is made by a spinal X-ray study while the child is in an upright position. Treatment is aimed at correcting the curvature and preventing more severe scoliosis. Curves between 20 and 40 degrees will require the use of a Milwaukee's brace. You can see a picture of this on page 585. Transcutaneous electrical muscle stimulation, or TENS, and exercise have been proven to be effective in the treatment of scoliosis. Severe scoliosis beyond a curvature of 45 degrees will necessitate surgery to fuse the bones and stop the progression of the deformity. Helping the teen cope with a body brace and maintain a positive self-image is important and a challenging aspect of care. Much postoperative nursing care is directly related to combating the physical results of immobilization. Postoperative exercise, physical therapy, and promotion of adolescent school and developmental tasks are essential aspects of nursing care. Several factors can help to prevent sports injuries. Some of these are adequate warm-up and cool-down periods, year-round conditioning, careful selection of activity according to physical maturity, size, and skill necessary, proper supervision by adults, safe, well-fitting protective equipment, and avoidance of participation when in pain or injured. A few or more of the common injuries are listed in Table 24.1 on page 586. Family violence includes spousal abuse and child abuse, neglect, and maltreatment. Parents should control the time spent watching television and the content of the programs so that television exposure will result in the acquisition of knowledge, skills, and information that will motivate learning. According to the National Center on Child Abuse and Neglect, the incidence of the following aspects of child abuse have been increasing: emotional abuse, emotional neglect, sexual abuse, physical neglect, and physical abuse. Children who are different from others in any way are at a particular risk. By 1963, the U.S. Children's Bureau drafted a model mandatory state reporting law that has been adopted in some form in all states. You can read a bit more about this in the Legal and Ethical Considerations box on page 588. Nursing interventions for high-risk children is of the utmost importance, and you can read more about specific nursing interventions on page 589 within box 24.1. Individual nurses can help detect child abuse by maintaining a vigilant approach in their work settings. Record keeping should be factual and objective. Direct questioning should be kept to a minimum. The nurse should avoid speaking to the child about the parents in a negative manner. Being open to parents during this type of crisis is difficult, but essential if the nurse wishes to be a part of the solution rather than a part of the problem. The nurse should be aware of the child's needs and facilitate the expression of feelings of loss. Some cultural practices can be interpreted as physical abuse if the nurse is not culturally aware of folk healing and ethnic practices. Child Protective Services should oversee any investigation that is warranted.